All right, everyone, welcome. We're going to get started. Welcome to this webinar. We're really excited. We have two great speakers that will be talking about global perspectives on orthopedic research and how to collect and publish orthopedic data. My name is Hugo Giambini, and I'm the chair of the ORS Scientific Communications Committee. So I first want to spend a couple of seconds talking about the organizers of this webinar. This was a joint effort between different people. We have Federico Drury. He's the CEO of IFMRS. Dr. Abel Marcha, an orthopedic surgeon from Mohambili Orthopaedic Institute. And then we have us from the ORS, myself, Amel Sassi, and Julia Crosio. They're members from the Scientific Communications Committee at ORS. We have Jay Moan. He's the Advocacy Council Chair from the ORS. But I also want to thank those that are not in this slide, which were of huge help to get this done and for us to be able to hear these two great speakers, Anne and Tim from the ORS, their ORS staff members who helped incredibly move this forward so that we could have this webinar happen. This is also a good chance for everyone in the audience who's not involved with the ORS to become involved with the Orthopedic Research Society. We have the chance to attend webinars, but more than that, to interact with colleagues, attend annual meetings, volunteer for different committees, organize the committees, participate, get on leadership roles, network. So it's a great opportunity for everyone to become involved with the scientific community and the society. So without further ado, I will describe our two speakers. We have Mrs. Gracie Drury from Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences from the University of Oxford. And we have Dr. Billy Haonga, an orthopedic surgeon from Mohambili Orthopaedic Institute and Mohambili University of Health and Allied Sciences. So our first speaker will be Mrs. Gracie Drury from Oxford, and let's welcome, and I'm excited to hear her talk.
Wonderful, wonderful. Well, thank you so much for inviting me to share with you today, and good afternoon or good evening to wherever you are, and I hope that you enjoy this, and happy to take questions later on. So I work here in Oxford at the John Radcliffe Hospital and also across the road at the Botner Research Centre, where it's a multidisciplinary centre with orthopaedic, rheumatology and musculoskeletal science research. There are two parts to this talk. I'll share some of the research from a recent project which was based in Africa, the COSEXA Oxford Orthopaedic Link project, and I'll also focus on a specific hip fracture clinical trial in Asia as well. So firstly, many of you will be familiar or perhaps even members of the College of Surgeons of East Central and Southern Africa. But for those who don't know, it is an amazing college which has currently 14 member countries and a number of partner countries. And in 2012, University of Oxford started a formal partnership for a project in trauma and orthopaedics training. And it was multi-level so that it would work with different cadres involved in orthopaedic care. Was funded by the UK government with a number of other partners as well. So the training elements were some orthopaedic surgical courses, some clinical fellowships in children's orthopaedics, and some primary trauma care courses, so training the first responders of injured patients. And then the research fell into two categories, one larger epidemiology study, and then a variety of trauma research studies. So by the end of the project, there were 40 clinical fellows trained in children's orthopaedics at the Cure hospitals in the region. We held 7 regional orthopaedic courses focusing on different specialties, attended by orthopaedic registrars and consultants across the region. And we trained over 2,000 local health workers in primary trauma care over 550 local instructors, and this was through over 50 courses across. At that time, there were 10 COSEXA member countries. So I'd like to just outline the research that went alongside the training elements. So the epidemiology study was in Malawi, and there are many different methods for studies which are looking at how many people or how many children have musculoskeletal impairments. One method is a house-to-house survey, where you go and door to door and try and work out from your sample how many children have impairments, and then scale it up. This study chose a key informant method, which is really exciting because we worked with different members of the community. So, as the diagram at the bottom shows, the researchers identify key informants in the community, for example, local teachers or religious members of the community, or some others who are social workers. Those will try to find children in the community who may have impairments, and those children are invited to screening camps where they are then assessed by clinicians. And if they need treatment, they are then referred to existing pathways. So this type of study enabled us to estimate how many children need surgery, and that can help to inform service providers on what provision is needed in the future, how many operations might be needed, how many physiotherapists, how many crutches, and so on. So that was the role of this study. And so we shared our publications. Musculoskeletal impairment wasn't the only one. We looked at vision and deafness and other impairments as well. So as I mentioned, it was a great opportunity to work in multidisciplinary research and to involve the community and to gather evidence that could inform policymakers and help with planning services. And there is a guide now produced at the end of this study, which others can use if they'd like to try out this approach in their own setting for an epidemiology study. The next study I'd like to mention is a fairly straightforward retrospective study on the burden of trauma in district hospitals in Malawi. So that was audit, a review of medical records, but just to give us more of an idea of how many injured patients are presenting to district hospitals. Alongside that, we did a survey across the COSEXA countries on their capacity to care for injured patients. And so this used an adapted WH tool for situational analysis to assess emergency and essential surgical care. So looking at how many operating theatres, how many health workforce, how many wheelchairs are available, for example, so you've just got an idea of what is the hospital's capacity for treating injured patients. Then we also had a prospective research element to our work as well, and we set up a trauma registry, a pilot at Queen Elizabeth Central Hospital, which is a referral hospital in Malawi. And so this is looking forwards at, as patients come in, taking data about what is the mechanism of injury and what is the treatment plan and so on. And so some of the learning from that is really practical, thinking through who's going to collect this data in the team. Is it in addition to their normal workload? What's the motivation going to be? How will you actually expect people to complete this? And is the form designed to be as user-friendly as possible? And also, after the external funding ends, what are the plans then? So trauma registries can help to collect an enormous amount of useful data, but it's the practicalities of starting one and integrating it with the hospital system. There's lots of lessons to share there. So alongside the primary trauma care element of our work, we wanted to know not just running courses, but do those courses actually lead to a sustained change in practice and a change in knowledge and clinical confidence? Do health workers feel that they can care for injured patients as first responders better further down the line, not just at the end of the course? And so we looked at quantitative and qualitative data to try to understand that. We would have loved to be able to look at other types of data, such as impact on patient outcomes or mortality, but I'm sure, as you know, that's very difficult to collect and also to correlate with training outcomes as well. So the first paper looked the first 10 primary trauma care courses immediately before and after the courses? Was there a change in the participants' knowledge of trauma care and their confidence in providing trauma care? And then we were able to go further in our next paper to include contacting the participants after 6 months after the training to see if there was then any, if that was sustained, that change in knowledge and confidence, but also whether a cascading approach to training was effective as well. So not just the outcomes from the initial training courses in each of the COSEXA countries, but once those local trainers were then training their colleagues, were we seeing the same results in clinical confidence and knowledge change? And it was very encouraging to see an amazing quality continued in the training as it was rolled out in the COSEXA countries, with the local instructors training their colleagues. And finally, the qualitative element of this was looking at changes in practice reported by the participants at 6 months and understanding whether they felt they were able to provide care and give examples of providing improved trauma care in their setting. So some different types of trauma research that went alongside trauma training. We also provided some small research grants to orthopaedic registrars who wanted to get going in research. One of these was in Ethiopia, looking at the experience of younger children who had musculoskeletal impairment. So Dr. Tedros shared with us his experience of this qualitative research, which is that in this study, we set out to study the impact areas in the lives of children with musculoskeletal impairment. And we wanted to see what has been challenging and what is important in their lives and their families. Even though we're busy with clinical work, we always take time to do research that has a good impact in the service for the community. And this is one of them where we found eye-opening results. So we were glad that he shared his experience of doing research which not only impacted him as a clinician, but he felt brought benefit to the community that were involved in the research study as well. Snapshot of the different types of research that we were able to do alongside a study that focused a lot on training as well. So it varied, as I've shown, from surveys to medical records review, community work, epidemiology, exploring patient perspectives, and for those at different levels of their of training as well. And I guess the take home from this is that sometimes there are opportunities to do research in maybe unlikely places, and starting small or getting ideas for something can be where it starts. And yeah, I'd like that to be the take home from this part of the presentation, that there may be more opportunities than you might initially think. So a big thank you to those who are our directors at that time, Prof. Lavi, Prof. Pandit, Prof. Maguti, and also Dr. Linda Chikoto from Malawi, who was our lead researcher at the time. So moving on to HIT Care, which is a clinical trial in Asia. And I thank you to Dr. Pandey, who shared some materials for this presentation. So the rationale for this study is that, as many of you know, older patients are more vulnerable to fractures due to falls from standing height and bones which may be affected by osteoporosis. And in the UK, we know that 25% of hip fracture patients may die within a year, and there is a reduced quality of life for survivors. But what are the outcomes in low and middle income countries? We know that the number of hip fractures in Asia specifically is expected to increase to over 2.5 million by 2050. And we expect more cases in Asia due to a rapidly aging population. And the associated healthcare cost may rise to $15 billion. And we know that a multidisciplinary healthcare team will be needed. We know that there is evidence from high-income countries that multidisciplinary teamwork can help to reduce mortality following hip fracture. It improves patients' health-related quality of life and can reduce economic costs. But what about resource-limited settings? So the Fragility Fracture Network did a survey to map hip fracture services in Asia, and this helped us to get some funding from the UK government through the National Institute of Health and Care Research, which wants to boost research partnerships between the UK and low and middle income countries. Our collaborators are in 5 different study countries and also the Australian University of New South Wales. So the research question can be summed up as, can a multidisciplinary training and support package, which we've called hip care, improve quality of life and reduce hip healthcare costs for patients with hip fracture? Those eligible are 60-year-olds and over who need hip fracture surgery and are available for 120-day follow-up. So, for example, we would exclude foreigners who might leave the country before the end of the follow-up, and is taking place in 40 randomized hospitals in India, Nepal, Thailand, Vietnam, and the Philippines. So our plan is to compare the hip care intervention with hip fracture usual care in these 40 countries. It's a 2-arm cluster randomized trial, so 8 hospitals in each country, where 4 hospitals continue with usual care and 4 hospitals implement the hip care package. We want to refine the hip care package in the 5 study countries and see if it improves quality of life and reduces healthcare costs. So the project management group works with trial management groups in each of the countries, who then oversee the 8 hospitals who are recruiting patients. We have an international scientific advisory committee, a process evaluation team, and a community engagement group in each country. In each of the countries, we have the trial management group led by a principal investigator, working alongside a clinical trainee to give opportunity for research experience to younger members of the team as well. And here's the Nepal trial management group in working on hip care. When we are selecting and randomized hospitals, we want those ideally representative of the health system in their country, who are seeing volumes of over 200 hip fracture cases each year. So these tend to be the university teaching hospitals, and clinicians who want to be involved in research. The intervention focuses on 3 components or success metrics for hip fracture. So that's prompt surgery within 36 hours of admission, immediate weight-bearing mobilization after surgery, so that's within 24 hours, and prompt orthogeriatric assessment, reducing the risk of future falls and fractures, and we're aiming for that to be within 72 hours of admission. In practice, it means the intervention hospitals are holding regular multidisciplinary team discussions with access to a special dashboard of data on its own hospital's quality metrics. So around the time to hip fracture surgery, the time to weight-bearing mobilization after surgery, and the time to orthogeriatric assessment from admission. Okay. The control hospitals continue with usual fracture care. And there's a research study team at each of those 40 participating hospitals, which each then have a principal investigator, a trainee, and in the intervention hospitals, they have an advocate as well, so someone who's going to champion for multidisciplinary care. Then at 120 days, we follow up for outcomes with a health-related quality of life questionnaire, the modified new mobility score questionnaire, a resource use questionnaire, which also looks at their residential status. Alongside that, we're collecting data on complications and mortality. So that should give us a good picture of hip fracture outcomes in the control and intervention hospitals. The Australian colleagues are leading us on a process evaluation element with qualitative research that includes interviews and focus group discussions with patients, carers, and the multidisciplinary team at the intervention hospitals. And that's led by local researchers in their local languages. So that will give us more insight onto whether the intervention, what works and what doesn't work, as we try and consider, is it worth rolling this out? There's a community engagement element in each of the countries so that the patient perspectives can help us with improving the study and, for example, giving us feedback on patient-facing documents and dissemination. And this is the team in Nepal recently. So we're most of the way through our timeline. We've done the setup, the randomization, partnership meetings, and we're well into recruitment in most countries. And so next year we'll be finalizing the process evaluation and the data analysis. And then we'll be looking forward to sharing results. So partnership meetings have taken place in 4 out of 5 countries for open recruitment in 4 of the countries. And the monthly working groups are meeting in the intervention hospitals, reviewing the data collected to date to provide real-time feedback regarding that hospital's performance against these metrics of success. And we have over 900 hospitals recruited so far. I invited our Nepal team to give some reflections. They talked about screening, that over half of patients are managed non-operatively due to reasons such as multiple comorbidities or family refusal. So different attitudes to surgical care. The surgical delays they saw amongst operatively managed patients were due to limited resources. And they did have some challenges reaching the patients for follow-up via the phone network for those where there were language barriers or the phone network was difficult due to remoteness geographically. They saw that their next steps and opportunities are that overall awareness of hip fracture care is gradually improving, and there is a growing acceptance of multidisciplinary care for hip fracture patients. They see opportunities to develop the research culture and collaborations, and opportunities for policy level advocacy with the health ministry as well. Some of our learning points overall have been about how to develop some complex partnerships involving so many institutions and countries and hospitals, that to give lots of time for setting up the project with the different types of contracts and collaboration agreements and clinical trial agreements needed for all the hospitals, and supporting our coordinating centres, some of whom learning the research management for clinical trials and community engagement is new for them. Also, navigating the ethics and research governance in each setting takes time, and to listen to our local colleagues and to plan all the different rounds of submissions. And it's been a learning curve to work across all the different languages as well. Our stats and health economics team have had fun thinking about what does a 5-country cluster randomized controlled trial look like when we analyze the data. And I think, as in many projects, communication is everything when working with many different partners. So I'd like to thank our collaborating institutions, and I've leave the references there if anyone would like to follow up more later. And just a final nod to the Global Health Network. If that's new to any of you, there are some free training resources if you're interested in developing your research skills. And there is also a dedicated Global Musculoskeletal hub on there with a bit of signposting to some other groups who are involved in orthopaedic research. And if you would like your group added there, then please contact me and I can help with that. So thank you very much.
Okay, so thank you very much to my colleague for presenting a very good talk. So I'll also touch on Tanzania perspective, looking into data collection and publishing our data. I'll mostly concentrate on the studies which have been done at our hospital in collaboration with our colleague from North America and Europe. So this is my overview. And there are several studies which we have conducted in Tanzania. We started with what was called Tanzania FEMA study. And the interest here, when we started the study, was to compare between intermedullary nail and the plating. We had those two concepts where we had surgeons who were interested in fixing femur fracture using plate and screws, and those who were using nail. And we were interested to know if there's any difference in outcome. At the end of the day, those surgeons who are using plate, they all moved to nail. So our findings were more on intermedullary nail on femur fracture in Tanzania. So we have several publications out of that, starting with cost analysis to outcome and infection. The other study has been pediatric femur study. Our interest was to compare an expensive flexible nail versus cheap K-wire, because we know we are in a resource limited area, and some pediatric patient might miss their fracture to be fixed just because they cannot afford a flexible nail. So we were looking whether the K-wire can give the same outcome. I think the publication will be coming soon. The other big study which we did was open tibia, which we were comparing intermedullary nail versus an external fixator. Because if you fix patient with an external fixator at a certain point, you need to turn them into a cast or a definitive nail. So we wanted to see if there's no increased infection if you fix these patients with open fractures, closable open fractures with an intermedullary nerve. The other study was amputation study, which we were looking into accessibility and quality of life for patients who have above knee and those with below knee when they get a prosthesis. The ongoing study is what we call GO-TIBIA study. We are trying to compare local antibiotics versus no antibiotics on patients with open fractures when they are treated after debridement and closed wound. Then we inject local antibiotics. We want to see if that will reduce the amount of infection which we see in this area. It's an ongoing study. We have some publication on method papers, but we're still collecting data. Then the other one is musculoskeletal injury research in sub-Saharan Africa, which is a global health group on global injury, which my colleague presented. They were together in this study, and they were looking into the amount of research in musculoskeletal injury in our area. It's again an ongoing study, and we have some few publications we go. I'll talk briefly as we go. Now, why do we think that we have to think about musculoskeletal research? First of all, musculoskeletal research in musculoskeletal injury in our area is a leading cause of disability because we have high burden in our area. But these injuries, they impact productivity, mobility, and the quality of life. So we need to do research to know them better. And the current position in our area, research in musculoskeletal is underrepresented in a global health research. There's limited local data, and we rely much on high-income country data to whatever inference we want to make in our area. And the data which we expect that might be collected in musculoskeletal injury, as my colleague has also indicated, we have to collect epidemiological data, which might be incidence or prevalence. We might collect clinical outcomes like pain score, function, and imaging and diagnostic data, as well as health economics and access to care, which my friend also indicated on what is going on. Now, in data collection in our area, so you can collect data using paper, which has been the most common mode of data collection in our area, and that hindered progression. Currently, we are using electronics. So most of the study which I've indicated previously, we are using electronic data collection. And the challenge for data collection in our area, it has been because of limited infrastructure, inconsistent documentation. And you can see that picture. Those what you are seeing is an archive of our patient case notes. Now, if you want to do whatever research to go and find out all those case notes, it's not an easy job. So that limits people to engage into research. But now we've moved into electronic, things are changing slowly. And then you have a shortage of trained personnel, and you have culture and language barrier. But the major problem here is poor follow-up. If you're doing any clinical follow-up, then follow-up is a big deal, especially if you're in an urban area, you're getting patients who are coming from up country, and when they come here, they are treated, they cannot stay here for recovery, they'll go to recover back for a follow-up. Now, strategy to improve data collection, what we did here during all those research we've conducted, at a certain point we have to move to use mobile tools. And then we had to make sure that we simplify our data collection form, so show how we made our data. As clinicians, sometimes it's difficult to engage, so we have to task shift some of our responsibility. And you're seeing these guys who are holding camera are my health records, whom we train them to help on data collection. And as you task shift, you have also to think about training and capacity building for your personnel. Now, when you are you're collecting data, you need to have data standardization and quality. So you have to use validated tools, which are worldwide known, and you have to have consistent protocol for measurement, and you have to have the quality control and the monitoring. Now, you will see here study which we are conducting with global injury group. Our outcome data tools which we are going to use, we're going to use EQ5D, and then for function, we're going to use PROMIS and the resource use tools. And the other tools which we used on the previous study, we much concentrated on REDCap because of our collaboration with San Francisco guys. We were able to get access of REDCap L-on, but now the REDCap is pretty accessible to most of our institutions here in Tanzania. We are also doing a pilot on treatment guideline by AO Alliance, and we're using COBO toolbox for that standard guideline too. Also, you can use WHO tool for musculoskeletal burden assessment or data visualization platform. We used what you see there on your right-hand side is our REDCap tool for the Tanzania FEMA studies, which I have demonstrated at the beginning. But as you go on data collection, we moved into using technology, and we thought like using paper is difficult, so we managed to get laptop which are connected to a local modem, and it was pretty cheap, costing only $280, and this helped our research coordinators to collect data easily. And also we transformed into using mobile phone for image upload. If I said important, most of us that they were follow-up study where you have to do X-ray and upload those X-ray on the database. At the beginning, we were using a camera and it was double work, but when you have a mobile phone, take your picture and straightforward, you can upload in the database. So we had to have data monitoring because data quality is an issue in our area. So we had to have a plan of how to have data stored, and then we have to have a data interval analysis for quality. And what we were guided by our IRB is that we have to have 6 months analysis. And then because they were randomized study, it was crucial for that study to do an interval analysis. And we had to have a data safety and a monitoring board, especially now when you are doing local antibiotics. There are some outcome, there might be some adverse events which you have to pick them. If at all our intervention is affecting our patients, to be able to stop our study so we don't harm patients. So our data safety and the monitoring board is doing that work. For an outcome, we had an adjudication committee in all these studies we did. So we had an independent adjudication committee which helped us to like review of our study primary event or any complication. So they were investigating, they investigate and review events and they develop a consensus whether the outcome we are seeing is real a primary study outcome, or if we are seeing any complication, to ascertain that whether that complication is related to our study. So our adjudication committee did that. Now, I'll take you through the flowchart of our study, the way we did, and you see how we had to improve the follow-up during data collection. So most of the study, we started with pre-assessment, which specialists had to look into the X-ray and screen that, yes, this patient has a femur fracture or this patient has a tibia fracture, and they can be enrolled in the study. And then after the decision is made, like now for the antibiotics, they have to, a surgeon has to tell our study coordinator whether the wound is closable. And then if he says the wound is closable, patient will be randomized into the study if preliminary patient agreed to be involved. Then after that, after surgery, we have to see this patient 2 weeks for the wound review and care. And then later on 6 weeks, 3 months, 6 months, and 1 year for an outcome data collection. Now, as I said at the beginning, that follow-up is a big deal in our area. So we had to put some measures in place to improve the follow-up, which is pretty important, especially at 1 year down the line. Some of the patients won't see need to come if they've healed. You might see patients who are coming for your follow-up clinic if they have complication. Now, to improve the follow-up, we dedicated a research clinic, which is done on Saturday. And that research clinic decreased the waiting time for our research participants. When they come to the hospital, they will go to this designated clinic, they'll be seen quick, and off they go home. But they're given, the clinic is in private clinic setting where you don't have a long queue. And they had always to see a specialist who is an orthopedic surgeon, and always it was me or my partner, and we still do that at this moment, just for the sake of like building a trust and relationship with our participant. And to reduce cost, which most of the visiting they were visiting for our research purpose. So we had to like waive or pay for the consultation fee of our patient and pay the x-rays for them so that they don't incur necessary cost. Now we have to use a phone call them beforehand to remind them that next Saturday is your follow-up clinic. And if they don't pick a phone, we'll send them an SMS message, and I had to take several phone of relative or a neighbor so that they can be reminded that, you know, tomorrow is your follow-up clinic and you have to attend the follow-up clinic, just for the purpose of improving the follow-up. Now, the other study which I said we're involved in is this, which I'm doing is global injury group, and our interest. This study is divided into 5 work package, and we are now doing the work package 1, which is to just assess the injury in our area, but we'll go on for the coming 4 years to like see how much, if you improve research, if you can improve patient care. And in our area, the ethical consideration is pretty important, and you have to understand taking a consent in low literacy area where sometimes patient cannot understand English. So at a certain point, you might need to translate the consent form. In your right side, you see that's the consent form, which is translated in Swahili. And sometimes you might need also a presence of witness because your participant might not be able to read, so they cannot understand what is written on a consent. So if they cannot read, we always provide a witness to satisfy that they signed that consent. And then you have to understand the culture sensitivity of whatever you write in your consent form. And our Institute of Medical Research require that you have to sign a data transfer agreement whenever you are doing research in collaboration way. So you have to have that data transfer agreement form signed in both ends. And in a certain point, you might have community engagement. My colleague said very well about that. So in a study which we are conducting, we will also have a community engagement involvement, which we expect that during that community engagement, our participants will integrate patient and the community leaders to co-produce our outcome. We work with our patient, clinicians, and the methodologists to co-develop publications, social media, and national government and ministries to disseminate our findings from that big study which we are conducting. And from all the other studies which I said we have done here, so the dissemination has been either having an abstract sent at international meeting and the local meeting, whether it's a poster or podium. And we try to our level best that even if it is done in international meeting, then this has to be presented locally in our local association meeting. And then I have manuscripts also, which we submit into different journals. We have several publications I'll show as we go, but we publish international journals. But if our manuscript is not accepted there, we also look into publishing in our local journals. And sometimes, as you know, publishing in international journals is costly and sometimes it's very difficult. So we make use of our local journals. The issue of authorship, which is a big deal if you are doing a collaborative study. It has caused a lot of friction among researchers. So what we try to do in my institute is that we agree beforehand that who should be at which position if at all write a manuscript from the study we're conducting. So we have been we avoid. Now, these are the few of the publications we've done, and you could see I was the first author in that paper, and then other papers I'm appearing at different levels, and we have our collaborators also appearing as the first author, second author, in that way. So that helped in the capacity building locally, that local researchers could work as first authors, and sometimes they can sit at the end of the paper, and they should know the responsibility of each position. Now, the challenge to publish, as I say, you might have limited access to high impact journals, and you might have high barrier. English is our second language. Sometimes it's difficult to write in a good English that a high impact journal accept your manuscript. And you might have lack of mentorship as well. Now, to improve that, we realized that we can use an open access. So we have several manuscripts of ours which are published on open access journals, but sometimes we also asked for a waiver because we are from low and middle income authors, and we had that waiver to have our paper published. And these studies which have big grants, we did put in our budget for the publication cost. And sometimes we do ask for preprint, and the local journal has been our area of publication. In the research which we've been conducting, we have been collaborating, as I say. We have global North and South partnership, which helped us in capacity building and equitable authorship. You could see we have connection. If anyone is interested, my colleague who presented in the previous showed this. If you're interested to join in a global injury group, you're welcomed. You can use that contact for the connection. And now in the capacity building, we've been collaborating with IGOT, where we are conducting research question writing, where we train our junior guys to equip them with possibility of identifying a research problem, putting that research problem into research question, and then develop their proposals. Slowly, when they have a doable research, we assist them if they can get grants and have their work going. But I have been mostly training our residents with their dissertation which they write, and at the end of the day, they end up publishing the result. And we get support from NGO and global institution, and you can see the IGOT has empowered us a lot, and now we have the global injury collaboration, which also is helping the same. Now, what's the future direction for our area? We think artificial intelligence is coming and might help in remote diagnosis and whatever follow-up of our patient, which follow-up is a big deal. We can use telemedicine and data integration. We can also use the Global Musculoskeletal Research Network, the one which showed on our left-hand side. And you can use also telephone data collection, which we have publication which shows that sometimes you can use, because of the availability of a smartphone, most of our patients that have smartphone, even at a remote area, instead of letting them come into the hospital, you could assess them through the phone. They'll take X-ray and forward X-ray to you through WhatsApp, and they can take picture of them walking or doing whatever activities for easy follow-up. Now, in conclusion, the musculoskeletal research in our resource limited is an essential, and we still understand it is under-resourced, and we think that innovation and collaboration are key, and ethical community-centered approach improve quality and impact of our research. Thank you very much for having me.
Thank you very much for that interesting talk, Dr. Hanga. So I'll start with this one. Let me read it out loud. It says, does provision of some incentive money study participants help to improve patients' follow-up in LNMICs? And is it ethically acceptable? So I think this...
Yeah, that goes to me.
Yes.
Yeah. So it is a burden relief to our follow-up because in our normal clinical follow-up, patients are followed second week for wound review, and then they're followed 3 months and 1 year. And sometimes they're not shown at 1 year. But because of research purpose, we want them to show at 6 weeks, 3 months, 6 months, and 1 year, which they're not important follow-up for the patient care, but it's just for research data collection. Now, to not put so much burden on our patient, that's why we introduced that cost relief, which it was ethically accepted, and our ARB accepted that it was not cohesion because it was a small amount of money. It's not like a big amount of money which pushes the patient that I have to go to the follow-up clinic because I'll get money. It's a service provision. So it was acceptable.
Okay. Any other questions for the two speakers? As we think maybe, oh, okay, let me ask this other one. It says, I am Filippo, Orthopedic Research Fellow at University of Illinois, Chicago Biomechanics Lab. I'm very much interested in doing global research like this. What is the best way for me to engage and get involved in this kind of projects available for ORS members like me? I'm assuming that this is open to both speakers because it's a general question. So maybe Grace can take this on first and then Dr. Hanga second.
Thank you for your question. I think joining things like this to hear about others in the field is really important. And there may be, you're welcome to get in touch, but there might also be others in your institution that are also involved in global research where it might be a slightly easier place to start as well, or maybe starting up a global surgery group or something like that as well.
Dr. Hanga, do you have any input for that question? How do others get involved in specific projects that you're developing or working on?
I think we are open for collaboration and involvement of anyone who is interested to do research with us. It's only if he can suit on our objectives. We are open. We are collaborating with San Francisco through IGOT. So if he's interested, he can connect through there, and he always be welcome in Tanzania.
Okay. There's another question from Carl Lewis. Are there other clinical data points that can be correlated with the ortho data collected, comorbidity, childbearing, etc.? And Carl, this is, I'm assuming for any of the speakers, Grace or Dr. Hanga.
I'm sorry, I don't think it's something that I can comment on, but Prof. Hanga, would you have any thoughts?
I think most of the studies which have been conducted here in Tanzania, because of trauma, mostly are young patients, they have very little medical morbidities. But I think if we are dealing with senior citizens, yes, there are a lot of medical comorbidity there. The data can be corrected. We tried to correct some risk factors in our FEMA studies. We had very few patients who are smokers and who are diabetic. So I think if at certain point we'll do like now we expect to do the guideline for proximal femur fractures with AO Alliance. At that point, the comorbidities data can be collected.
Thank you. So here, there's another question for you, Dr. Honga, from Amel Sassi. It says, under the challenges you have listed, you listed a shortage of trained personnel. What strategies, if any, have been most effective for training research coordinators, early career physicians in accurate data recording and management?
Yeah, when we started doing research at our institute, that was a big problem. So we had to take time with collaboration from San Francisco, get somebody down here and train our research coordinators on how to use the red cup and how to really navigate through the research forms. And that has been ongoing. And these coordinators we train, they train other people. So now it's not a big deal for data collection. But I'm sure if another institute wants to start doing the same what I'm doing, they might face the same thing, that they might need to train their guys for understanding the tools and everything. But we are ready to help to train them. But in terms of research methodology and everything, IGOT has been also conducting 2 days research method training every year. So that helped to equip also orthopedic surgeons who are not interested in research to at least get some nut and bolts on how to conduct research.
Thank you. Okay, another question popped up. This is, another one. We're good here. This is encouraging a lot of discussion. So in terms of study participants, is there any disparity between males and females? This is from Aditola Adesida. Is assuming, I don't know who this is going to, but it's relevant for both speakers, I guess.
I think it's quite a general question, but
Right.
Some factors which could make a difference would be whether people have access to mobile phones, whether they are and can be reached for follow-up, and whether they are the decision maker on whether they can access care. For example, whether they can, even if they're offered care, the decision maker might be someone else in their family or a community leader. So that can affect study participation in some cases.
Okay, thank you.
I think in Tanzania, what we are seeing in musculoskeletal injury, majority are male. We have very few female, especially this young group. As they start getting older, start seeing more female coming up. But we have no restriction for participation in relation to gender. Anyone has equal access.
Okay, thank you. I think we have time for one or two more questions. There's another one here. It says, is it a requirement to have a GCP certificate and human subject protection from Citigroup for local research? Do we have a local equivalent? And maybe that's for you, Dr. Honga.
So in Tanzania, yes, our Institute of Medical Research require a principal investigator to have a GCP certificate. And especially if you are doing a randomized trial, a GCP certificate is mandatory. They don't have a restriction where should you get it. You can get anywhere provided you provided a valid certificate, they accept it.
Okay, we're right on time. There's probably a lot more questions for both of you. I think we're going to stop here. Thank you both very much for the webinar. Very informative. I have a lot of questions I couldn't ask, but I hope it was fruitful for the audience, and we could see a lot of different things happening in other places than the U.S.